I imagine that it is not easy to go from convincing a patient that he can hardly move, that moving is better. It must be very complicated. It is the building part of the now. I wanted to ask Maria Jesus why in these active coping units it is true to correct me that I miss the role of nursing, not that they are led a lot by doctors, physios, psychologists. But I miss the role of nursing and the question is, what more proactive role can nurses play, for example, in the pain unit? Are you complaining? Well, I lived it, I know the pain units. You are nurses. Sorry. Mere installation instruments. If you could encourage a little and start introducing those changes and that education? That's it, I answer. From the level personal and tactical, I in the unity of pain with work. But it is true that with the support of some of the comrades. For a few years now, I started with a consultation. Specific education and help to cope with pain. What does that cost you? A lot of effort, first that your colleagues believe you and then that the management creates you to allow you to be there. This was ultimately translated. Well, in some workshops that we have been carrying out, especially with patients with primary pain. Above all, training to promote self-care. It is a struggle, they say. I think that in Galicia only Vigo has this nursing consultation. I think it is something in which we can contribute a lot because in the end, as I said before, we are the caregiving profession. Therefore, we are the besides. A bit of the health backbone, because every patient goes through us. And of all multidisciplinarity, it ends up with us, we are the ones who spend the most time with a patient. Does the patient see a specialist while the patient with whom he spends the most time with the nurse is hospitalized? Does the nurse live the 3 shifts with the patient? Do you know what specialist X told her? And your family doctor knows pretty much everything. The problems that the patient has when they do not understand medical language, when they have doubts about anything, who do they ask? The nurse. That what I was telling you before, the problem of communication is fundamental. Many times we are not aware, and especially at a medical level, of how we are talking to patients, we are sentencing. And the sentences carry many times to the patient to slow down. The most recent experience yesterday in consultation, I had a patient who when I told him, well, you have to start exercising. He told me impossible. The doctor told me that my back was shit. Thus, verbatim. What is he going to do? Believe me. To the nurse on duty who tells you not to look. It is that his back, if not, begins to strengthen the muscles. Is it going to take more of a toll on it? Of time. Okay, so I think it's very important how we communicate, it's important. The role of nursing as a trainer of self-care, and that health education, I totally agree. Well, Sergio, I am also a family doctor. So I have heard you say that we have sufficient resources, we have exceptional professionals. Okay, so I think the evidence says attention. So 2 things, 1, do you think that the resources in primary care? This is a question that has not only arisen from me, but also from Professor Carrillo, because I believe that it is a reality. Are the resources in primary school sufficient at this time? I am not talking about the quality of the professionals, which I have no doubt about. Are primary care resources now sufficient? And I believe that there is a program for implement psychologists in primary care. Because we don't need to. That there are psychologists in primary care. Physios, we have obtained physios in primary care. Does that mean it's not necessary? What, because we know the waiting lists of mental health units? So, it's not necessary? That there are even more resources, or how do we propose to a primary care doctor who is 40, I am not going to talk about 50 or 60. But it has 40 patients. As we told you, because it is not only the pathology of chronic pain, it is that grief comes. Complicated diagnoses come, family accompaniment comes. How can we tell a primary care doctor what he has to remove? I think it will happen like that. Excuse me, I think that at least 20 minutes is needed for the first entry at least, and I think I fall short of being quick with the patient. Need a patient with this type of pathology. That I am going to answer you by taking up what I have done. To continue to discuss The resources are there. In other words, the chips are on the board now. For physios. Of course, if we want to treat the patient with chronic pain well, there is a lack of physios. And I ask Susanna, if she lacks rheumatologists, isn't she going to say yes? I'm going to tell you, there is a lack of doctors. And it is a very simple mathematical calculation. When I start in the morning at 8, I have 7 minutes per patient. Is that valid when I took away the mania of the administrative staff to make appointments from one day to the next? I didn't understand that concept. It was emergencies from today to tomorrow. Then, when the game starts, I start with 7 minutes per patient. Every time a patient walks in without an appointment, I have 3.5 minutes left. Of course, 3.5 minutes for every one. If I have 2 emergencies in those 7 minutes, I have 2 minutes for each patient. Obviously, we don't regulate like that, no, but now tell me in that middle of the morning where I get wind for 25 minutes. For a single patient who needs them. Surely you need them more than everyone else. What is needed? One obviously more personal and probably, I insist, manage in a different way. What we're doing. No, the system cannot be action-reaction. Oriented to an acute pathology. Which is now the minority of what we serve. Of course, a tsunami of old people is coming from another. Summary yesterday. And I like that you talk about psychology. We are one of the centers that have a psychologist. Congratulations. A luxury, because it's true, as every pilot program focuses on. A very specific group is the anxious depressive adjustment disorders. But for us that is very important. Why? Because those patients that we now send to the psychologist and in 15, 20 days they are fine, she is seeing them. Before I had a 9-month waiting list, a mental health unit where they were mixed with patients with schizophrenia, patients with much more severe pathologies. They arrived 9 months later. Very medicalized on our part, with a lot of medication doses, when their problem was different and we could not address it, right? Here we talked about psychology for pain before. Of course. When I say, and this patient with chronic pain who has affected his emotional state, and it does not surprise me. Not sometimes, because the depressive problem is the cause, is that it is the consequence. I have to send him to the mental health unit so that he can be seen by the psychologist, a mental health unit mixed with the rest of the psychiatric patients, some of them very serious. You will say, Astia, I'm like maracas like this one next to me, right? What you have is pain and an emotional reaction. Normal to that pain that we have not controlled. In other words, the resources are there, we don't have to invent any profession, we are all there. What happens is that we have to reorganize ourselves in a different way. Not only for chronic pain, but what concerns us and is what we are going to address. But what we have to do is reorder the resources in a different way and see which patients need or more resources or the resources in another way. Yesterday I came from a meeting and forgive me, only that I get out of the chronic pain for 1 minute. Patients with heart failure are a headache for the hospital, it is the main cause of admission in Spain. At the hospital level, and they take a lot of resources. We have managed to agree on several specialties, several professions, including hospital computer scientists. What have we achieved with that? Are those patients going to be marked? The moment a patient makes an appointment, I will see him at the time he touches the hospital. The next day, 48 hours later, he will have an appointment with me in the consultation to prevent us from being arrested. Decompensate. At home, and that they do not ask for assistance for whatever reason. And that way of caring for patients in others. In countries and in other health areas, it has been shown that this patient can have an average of 10 admissions per year. To have between 2 and none. Just with that, just keeping an eye on the most or scheduling checkup appointments. Obviously the volume is much lower. I can have my quota 67 patients with that, with chronic pain I have many more, right? But it is an example that if we organize ourselves, are there results in SAN? And we have to start changing the health system, because, and I repeat, it is a well thought out system. For acute pathology. What do you diagnose, treat, solve, and go home in the reality of our population? Right now I am totally. In any case, I wanted to make an addition to what I think we sometimes forget when it comes to managing who we manage. I mean, the population we manage has changed. The population before I worked a lot in the countryside. It was not very demanding. Now the population is. Because that's how it is, society, I always say, is of immediacy. And of solving it for. Or we do a lot of health education, we even change the inertia because this happens not only in health, but in life itself. I mean, I want to. The one or we go, come on, we have. Very complicated management. That other resource, because sometimes we talk about resources. Human of time. What I think the first one needs to be managed is the time resource. But the resource time is very easy. If it were easy, this was it. But we can be more efficient. I didn't comment on it before, there is evidence that is not there. But since we do a care process, I put in black on white when each of the tests is indicated or not, quite a lot. What clinical situation? If we are all clear about all the protagonists, that this test is indicated, I don't have to. It allows the patient another specialist to be the one to order the test so that the patient returns to another list. I'm already asking for it. I know the pain syndrome. I know that the test is indicated and I know that I cannot ask. And I also know the ones that are not indicated and that supports me. It also serves me to say no, it is not that it is not indicated, that it is indicated. If applicable. As patients this other test. What we have to do. No, but of course, for that you have to put it black on white. We all have to agree. What do we do in the face of each? And as I say, it is not easy. We are probably talking about the most complex syndrome, because behind it there are many very diverse diseases. But if we are able to do that and organize the system, this is facilitated. I am not saying that this is easy. I have to discuss a lot, work a lot. But it's easier, of course, if everything goes towards a reaction. A patient comes to me with pain. I solve it as best I can. He comes back because he is poorly controlled. So are we also generating? Self-suing because we are not being decisive. We have to try to be decisive, to analyze. And above all, to return. At least Susanna knows it. In our area we are working a lot. That the professionals communicate, that is. With the time of that, I am older than when I started medicine and I started in a small place that was Lugo. We knew those of us from the health center in Fingo and with those from the hospital, now the people. It seems that he has not studied the same career or done the same specialty. So we have to go back to what he was saying? Done what you said before, something as basic as communication. I mean, yes. To know that I don't have to ask for something, I have to agree with the other party and that can only be achieved by communicating. And forming the. There are people who have a lot of initiative and are trained a lot. But do we have to form in common, does that mean? We both have shared days where the hospital specialists go to talk to the primary specialists. Because that is another concept that we primary school specialists have to change. Okay, and then put things in common and probably get a little bit of what you say. And finally, I don't miss out on asking Susanna. Since you are dedicated to research, what strategies could be implemented to promote research in chronic pain in the field of rheumatology or others? Not to promote, not to be individual initiatives. Otherwise, how to reach professionals so that they get the bug of wanting to investigate in this matter? Well, I believe that the answer to this is not only for chronic pain, it is for all kinds of research. That is, I believe that we have a barrier. And it is that research is. And is it done? For the love of art, right? Neither do the systems. They always allow. Probably because of the care person we have. The fact that one day we can stop and think, well, I'm going to dedicate this line of research, I'm going to dedicate myself to this other, right? But it is true. In the teens there is a lot of responsibility when it comes to promoting the research bug. And I believe that this has to start from the faculties of medicine. Even the residents. Until. Well. Already. When do the assistants already have their place? Yes, but I think it is also very important, not only for research, but for the approach to this type of pathology. Patient associations, us. When from the point of view of care. We work very closely with patient actions. It has an associative space in the hospital. And we often prescribe them apart from what we prescribe. The telephone number of patient associations for them to contact. Not with them, so I think this is teamwork. A need arises. Social a need arises on the part of the patients. And that need? Does it have to be transmitted in some way? Not to the professionals who are here, who have the responsibility to attend to them, right? And well, I think that more and more, at least in our community, research is being promoted, that is, of what it is like now. What was it like? It has nothing to do with it, I do perceive support, not for the projects. Research. And although it may not seem like it, there are many. Do we really judge? Because of the work we have in the Ethics and Research Committee. I tell you that they are many, which I am happy about, and I am glad that we lack time to evaluate. How many jobs do we receive? It is good and good to congratulate, then. To the scientific community. Congratulate and then too. That there is more and more research in the area? Primary care. Christians are beginning to arrive studies. And also the nursing area. I also believe a lot in teamwork with nursing. In fact, rheumatological nursing was one of the first specialized nurses that has existed. Ours, I'm not going to say how many years it has been there. But decades, right? And I always say it with a small mouth, and that the managers at my service do not hear me can work without a rheumatologist? But it couldn't work if the nurse. No, because and we work very closely with her, they come to our congresses, she brings communications. Well, and it's the angel, not at the time of relate with patients, but I believe that the coordinated activity with patient associations. It is also fundamental to establish needs. Of course, I think it's to improve, and to know if we're on the right track we'll have to ask the receivers. Well, we are doing our work well. Questions? Thank you. I would appreciate you with the questions, that if it is to the table in general or if it is a specific professional. Will you specify it in the question, please? Hello. Good morning. Well, my name is Lucia Fernandez. I come on behalf of the Fibrobies Association. From Coruña, and which? Because I'm talking to a lot of people who are in the group. You are congratulated by the Bureau for having said so many realities. And is my question a good one? It can be done at the table in general, but well, it is more focused on physiotherapy. And it is because physiotherapy is not performed. From public health. Those of us who are labeled with fibromyalgia? The reasons are multiple. No, that is, it is not due to lack of interest from physiotherapists, that is, we know that it is one. They are patients that we have continuously, they are patients that unfortunately. There is no approach to a discipline that works. And that he can be treated? So they are the ones who are bounced by the system, they are bounced from one consultation to another. And in the end they end up in physiotherapy. Because well, you have to exercise, you have to move, you have to. We, from which we publish the portfolio of services, have a program focused on this type of patient. I believe that there is sufficient scientific evidence that supports our conservative treatment interventions. Based on education and movement. No, what these programs need is the ability to be able to manage resources and direct them towards another model. What Sergio said, if we have a model which focuses on urgency in acute pathology. And we are treating chronic pain as an acute pathology maintained over time, it does not work. So, if we also talk about the sustainability of the system, because we say come on, the patients go, we park them, but this is cost effective, it is also cost effective. Chronic patients are the ones who generate the most demand for resources, they are the ones who generate the most spending. So, do we have to change the model? Why are they not applied, then? On the part of the physios, because we do not participate in mesomanagement and macromanagement, that is, we do not design health policies, and we do not even have the capacity to define the number of resources needed or the care processes where we can participate with an evidence-based approach. In other communities, what has been done? Well, fibromyalgia patients will comment on it in the following tables. They have attention in these programs. They are provided with tools, they are provided with education is explained to them what is the physiological mechanism by which they have that pain, why they have fatigue, why they cannot. And when the patient understands it? When the patient understands what is happening to them, they do not improve their functionality because they know that they are not there. Harming us is harming us, not what Rosa told us. Just as you tell someone that it hurts to move when moving? Well, of course, you have to make a path with that person. You have to accompany her during the process of change, so that she understands her pain, so that she understands why I am in pain, because my brain responds in this way to a movement that should be something natural. So we as physios and I personally am determined that they are put in place, not that we focus the resources of primary care physiotherapy to give programs or to carry out programs. For patient, chronic pain, metabolic patient, mental health patient. Not that it's a little bit what our portfolio that we just released is based on. To rely on the Galician strategy of community care and incorporate the community because it is an educated community. A patient pays more attention to his neighbor who says, "Hey, I went to the program, this one is much better." And he says, "Hey, then I also want that program." No, but the community has to understand what is being talked about. And hopefully soon they will begin to open these treatment options for patients with chronic pain. And always with a multidisciplinary vision, because we will need, of course, the help of the psychologist, the help of the psychiatrist, the rheumatologist. It's because he's not a patient with chronic pain, he's not. 100% chronic pain can also have implications at the level. Articulating at the level of tissues at the level of others is a complex pain. That we all have to be there. That is why we have to make that alliance. It has to be multidisciplinary, it has to be as soon as possible, and it has to be based in education and movement. Well, I really wanted to do it a little bit as a bridge to others. Tables that are going to emerge and other debates to follow. But well, I also speak here as a personal experience. I am a clinical physiotherapist and then also I dedicate myself, I'm doing some research in pre-doctoral training in education and neuroscience of pain. And there is a good thing, and I think so. A kind of dichotomy that I even think I've been hearing all the time at the table about that. We must improve the approach to chronic pain. Because it has always been too based on the acute management. Don't you think that also acute management? Should it be different? That is, why do we have to wait for it? Although a patient has to come. 10 years later, what do we say about the beliefs I had before? And they were not correct in that all the information, since maybe he had a sprained ankle for a while and was told not to move it. Be careful. And you have to wait for them to tell you if you should have gone to the psychologist before, and you are not given that option from the beginning, that is. Because we are thinking that the biopsychosocial model is a model for the chronic and we are not integrating the acute. It is an open question. I have doubts that we are. I have doubts that we are talking about the same thing, chronic acute, right? One thing is acute chronic. Not that at the end of the day he is still a chronic patient. To the acute one, which is the one that comes through a short-term process and that you resolve on the spot. Okay, then, and obviously, another problem is the acute one that you treat badly and have sequelae. But things are different things, aren't they? Here's how we talk about chronic pain. In general, I think the problem. It is not only in attending to them in their decompensations, which must also be done. An immediate response must be given. Not as much as the causal diagnosis of their problem and starting that more or less chronic treatment they need, because when I manage it, daily chronic of chronic patients, is his decompensation correct? And his discomfort? It is relegated, that is a reality. Then, obviously, he will have his decompensation like any chronic patient. But if we handle it well from the beginning, we orient it well from the beginning, the evolution is going to be much better. The reality of from our day-to-day life with patients with chronic pain. It is what I said before, they remain around the system, that is, they are not resolved. They cannot be resolved. And what must be avoided is that they are circulating through the system. Without a solution, but of course, in the end the patient who does not solve his health problem. Of course it gives ague to no service to another. I want to make an aside to what you say. I don't know if I have understood you. What do you mean that education has to start from the acute phase? That is, if we tell a patient to be careful that a lot of damage can be done, that the ligament can be completely torn. We are generating beliefs that weaken it. And I may tell you later my ankle is hurting because it looked bad on me. When we know that scarring is going to happen. And what was wrong is a belief that that ankle after the sprain will never be the same again. No, it will never be an ankle again. Stable, exactly. And perhaps someone has started a subsequent chronic process because it left something acute in a certain part, which could be a trauma or another causal factor. And from there, maybe he has experienced an event X or Y and suddenly this begins his process of sensitization, which is explain at level, that is. Or at the level of pain or at the multisystemic level why we are waiting or managing ourselves or. By proposing education in chronic pain, I say it by doing education in chronic pain. But many times I think that we are late, very late. Why not from the beginning in primary care? There is a common message, there is. Physiotherapists in primary care, that is, in the hospital itself or psychologists, that is. The one of the first times it is arriving. What am I going to wait for? When I'm already seeing X flags. To everything else, and why is there no me? They also had battle and monster. Proposed education programs in management in education. That is, in the acute patient in acute pathology X sub I. It needs education and then, obviously, the messages we are transmitting to him. Each person, each patient, is super sensitive to the information and messages that are being sent to them by a professional. The white coat makes moo. Any kind of explanation may come to you. Like 20 years later. Be there in your head. Why are we there all the time? Well, chronic pain education, right? I think the model has to be comprehensive, including acute. Excuse me, I think that maybe the problem is to start from that. What does the process start with? I mean, in general, acute processes. They are usually associated with organic injuries. I mean, an ankle sprain has a ligament injury. So, that? I believe that it does imply a diagnosis, a treatment, often a pharmacological treatment and an education. For what? But I believe that this is done. What do you mean? I believe that what the biopsychosocial approach is given by the primary care physician when he is seeing him, because he already knows him, he already knows what his repercussions are going to be in the workplace. What is going to affect your daily life, that is already known by the primary care doctor. I think this approach of biopsychosocial. It is referred precisely for pain. From neurosensitization, I think they are. I think it is. Acute pain is not denied the holistic approach. To worry about whether he will be able to go to work. Well, if he will be able to live. But he does have an organic injury that he needs. A treatment cannot also be discarded, pharmacological treatment. And it needs some care and so on. But then. Yes, that pain is usually limited in time, if that pain is perpetuated. And it conditions, indeed, you have to search. What are the motives and focus? What exactly is all that encompasses that pain that is perpetuated and that conditions the patient's life? But indeed, you have to. That we have to make a difference? I to close it alone. It is very proven that it has more impact on the prognosis and on the evolution of acute pain becoming chronic, the beliefs that the patient has more than the pathology they have had. That is, I can have an acute event. And this pathology will have a process of healing and tissue repair. That it has a prognosis, but if the patient has a wrong belief about that process, you will have a much easier time developing chronic pain. That if he does not have those beliefs, then I think that what happens is that we cannot generate erroneous beliefs in the acute patient because then we will have a greater chance of developing pain. Well,